Welcome to All Things Chiropractic.
Well, welcome to another episode of All Things Chiropractic. I'm Paul Andrews.
And I'm Dr. Mark Davini.
Today, we're going to talk about inappropriate conduct, which I like your title, A Touchy Subject.
It is a touchy subject.
That was cute.
Every pun intended and no insult meant.
So, to the overlay or sort of background of this, if you haven't listened to our introductory episode, is that we both come from a regulatory background as well. I currently sit on my massage state therapy board as chair, and I can certainly tell you that we have seen a very large uptick in the inappropriate touch issue as far as complaints go. So, and we can certainly, I'll let you from the chiropractic perspective, because we do a lot of, especially you do a lot of med defense work.
Right. It's interesting when Paul is chairman of his licensing board, the massage board in Massachusetts, they often are the ones that are judging the case that comes before them. And from my perspective, I am always the one trying to defend the case. So we really have two different angles to the same problem here. As a board member, or especially chair, his charge is to protect the public. And certainly as a defense expert, I try and do my best to defend the doctor. So we bring in a couple unique push-pulls here and counterpoint, if that's the way you want to put it. So it gives us a unique experience from a regulatory perspective, but from two different angles. But, chiropractic in particular is we'll say a profession that results in inappropriate touching complaints. I mean, think about it. Chiropractic is Latin for done by hand. We touch people. It's what we do. In fact, it's one of the things that make us better in a way than other clinicians, in that a lot of patients feel like they never get that personal attention. But like all things, there's a right way and a wrong way, or a good way and a bad way. I mean, just from a general perspective, 9 out of 10 obstetricians are sued for some type of inappropriate conduct. And obviously we know that what they do also is very risky and results in a lot of scrutiny. Most of the people who complain are females, and most of the doctors they complain about are males. That's just statistically true at this point in time, though that may change as time goes on, as we have more and more blending of this whole gender discussion. So you have to be aware that it's not just because it's a female patient and a male doctor. It could be a male doctor with a male patient, a female doctor with a female patient, and every other combination you can think of. But it does say most victims really don't even report the sexual violation, and Paul will back me up on this for a lot of different reasons, which we'll discuss. But really, you got to look at it as like 1 in 10 complaints actually get filed for inappropriate conduct types of behavior. And they can be approached from 3 different angles. And a lot of times I don't think doctors recognize how serious an allegation can be. Not a conviction or not a ruling against you, but even the allegation. Number one, they can come at you through your malpractice. Well, you go, okay, that's what I have insurance for, whatever. And for the most part, it will be handled through your malpractice, and it may or may not affect your business per se, your reputation, depending upon how public that malpractice case becomes, which most commonly they don't become public. So it can actually go before your state board. Now your license is on the line. Now there's a chance that you may have your license revoked or suspended, or at least modified, or some type of sanction against you. So if the board were to rule against you, there could be repercussions to your livelihood. And then there's a criminal charge. They can actually file a criminal charge for sexual assault. And even though you may win that case, you're put out there. Dr. So-and-so is in the paper and has been charged with sexual assault. Now, we know that down the road, when you're proven innocent, most likely or hopefully, the same level of announcement won't be made. So sometimes just the allegation, just the complaint itself, or just the claim that there was an inappropriate touching or inappropriate conduct by you can be damaging. And that's what we want to talk about today.
And before we get into sort of more specifics about inappropriate touch and also some advice for all you doctors out there, these three types of complaints that Dr. Davini just outlined, the malpractice, state board, and criminal, they're also interconnected, because if you have a malpractice case that settles in any way, you go on a list, and your state board, whatever state you're in, they monitor those lists, and then they look at that malpractice complaint and settlement to see, do they need to take any regulatory action on your license based on a malpractice settlement? So you may think, all right, well, I sweated out this malpractice for 2 or 3 years, and now, thankfully, it's behind me, but it may not be behind you quite yet from a regulatory standpoint. And then the connection between the criminal and the state board as well, because criminal obviously it's the worst, right? So you may be facing jail time and all kinds of criminal issues to deal with, not to mention your reputation. But just the mere fact that you were charged with that could end up at the state board level. And then they, I can't speak for every state board, but I can tell you from just precedent that many of them will open a complaint and pend or table the complaint until there is some kind of resolution criminally. And then they'll pick it up and decide what they do or not want to do.
Yeah, and a state board also has the power, or most state boards have the power, to suspend your license pending the outcome of the investigation of the criminal complaint. So again, you might not have done anything wrong, but there are repercussions to the claims themselves.
And then, because they're all interconnected, if you have a state board complaint that may be used, whatever the outcome or resolution or discipline of that state board complaint could be used for a malpractice case, right?
Exactly.
So they're all connected, fortunately and unfortunately. If you're looking at it from a public protection perspective, yeah, they should be all connected, right?
Exactly.
I'm doing my regulatory duty as a provider who says, I was falsely accused and I have to deal with this now, and look at all the different ways that I could be having to defend myself. Yes, that is correct. So part of our charge today with our podcast is informational, but it's also maybe to give you some advice along the way too, from our perspective.
Right, because it's such a current thing that's going on. So, Paul, so what are your perceptions? What's your perception of inappropriate touching? Being a massage therapist, being the chairman of the board in Massachusetts for massage therapy, you obviously have some perspectives here that
Sure.
would be interesting.
Let me start with a generic but very real example of what we see on the massage therapy board. Okay, so I'm speaking as Paul Andrews today, not as anytime I'm on this podcast. I'm not speaking as a board member for massage, but with my experience, it was very surprising to me as I started to look at these dockets, look at these complaints, and see a very a lot of commonalities with these complaints. And so I'll give you a general complaint, Mark, of what we typically see. It's a female client and a male massage therapist. And that's the scenario we typically see. Not exclusively, but typically. The female has seen this male massage therapist before and never had a problem. But today it felt different. And this is what typically gets written up in the complaint, right? Just it seemed different this time. And the female client went in, got undressed to their level of comfort, whatever got underneath the drape, and the male massage therapist came in, started working. Everything seemed the same, and then it wasn't the same. There was some inappropriate touch. There was some misunderstanding. The draping wasn't tight, or the therapist went below the drape or underneath the drape, or there was this blatant touching. I mean, of any kind. It could be, on private parts of any kind. The female client freezes, doesn't know what to do, may or may not say no, or may not say, well, can you move on, or may not say anything. Typically, they don't say much. Then the session is over. The female client comes out, goes to the reception desk, pays for the massage, gives a handsome tip for the massage, reschedules with that male massage therapist for another appointment, and leaves. And then as they start to process what happened, and they start talking to their spouse, significant other, friends, they realize this wasn't okay. And then the complaint gets filed. Now, sometimes that complaint is through the local police. Sometimes it's through the board. Sometimes it's both. But it was shocking to me at first to say, okay, well, geez, they didn't say anything. They didn't scream out. They didn't make a ruckus. And when it was all over, why did they reschedule? Why did they tip? Why didn't they say something to the receptionist? And, my assessment of it seems to always come back to there is fear. There's fear for their safety. They're trying to assimilate what happened. Is it did it happen? Was it okay, not okay? Depending on the severity. Some things are pretty blatant, pretty sinister, and, they're fairly easy to recognize. But a lot of times it is a he said, she said situation. And looking at it from a public protection standpoint, oftentimes an emergency suspension will occur. And depending on the state you're in this state, there's 10 days. You get 10 days for that hearing. Within 10 days, it has to happen on that emergency suspension, and whether or not it continues to be suspended. So starting with that in mind and understanding that, looking at, the perceptions of inappropriate touch, I guess another question maybe you'd ask is why? Why does it happen? Or, if it's not a sinister, non-consensual action that was deliberate, why would somebody complain about inappropriate touch, right?
Well, going from the other side of that, the doctor gets this complaint, and what are they going to say? They're going to say something like, I just did what I do. I needed to be there for this reason. And their notes might even document a clean, clear clinical reason for being there. And so I did this procedure and that procedure. And it's very common among procedures like manual therapy techniques when you're doing release techniques or myofascial release techniques, things like that, where you have to be touching parts of the body that may or may not be related to the area of complaint, at least from the perception of the patient. It's interesting when you look up a couple definitions of inappropriate touching, you get one that would say it's engaging in any contact with a patient that is sexual or may be reasonably interpreted as sexual. That's one. And then another one is inappropriate touching in any physical contact that makes you feel unsafe or uncomfortable. So what's the commonality here? The commonality is interpretation in one way or the other by the patient. And in their minds, if they interpret it differently than what you think it should be or what you intended it to be, hopefully you didn't intend anything nefarious, but if it's different than what you intended it to be, but yet they interpret it differently, then it becomes non-consensual, at least in the minds of the patient. And that's the push-pull we're talking about, where you have to weigh this balance between what one said and what the other one said and say, okay, who do I believe? They both have a relatively decent explanation of what's going on. And that makes it very difficult to choose whether, sides in a sense. What is it that is the deciding factor? So, some things are clean cut. I'll give you an example of one is, we had this doctor when I was on the licensing board, or just got off the licensing board, and it was one of my first gigs, we'll say, as an expert witness, only this time it was an expert against the doctor. I testified before a grand jury because this doctor was convincing women that his x-ray machine was not powerful enough to go through a gown. And so when he took x-rays, they had to drop their gown. And this happened regularly and over reasonable period of time. And I know your mind goes, wait a minute, well, who would do that? Who would think that was okay? That doesn't make any sense. And like Paul was saying, a lot of times their answer will be, what do I know? They're the doctor. I don't know anything about x-ray or taking x-rays, so they listen. But just to give you an idea, once one person came forward with this complaint, 45 other women filed the same complaint. And I'm talking about, women from all walks of life. So it didn't matter what their history was, their backgrounds, the educational backgrounds, whether they worked or didn't work, whatever. They were women of all walks of life, and they were all convinced by this doctor that the x-ray machine was not powerful enough to go through a gown. So you have to be mindful that there is an interpretation. Sometimes, in this case, the interpretation seemed to work for the doctor for the longest time until one person finally spoke up and said, this doesn't make sense to me. This didn't feel right, like I said before. And once one person gave permission to say that it wasn't appropriate, other people looked back and went, you're right. Same thing happened to me.
So you've been in practice a long time along the way. So do you recall any time in your practice, Mark, that like this came up or could have come up, or any scenarios that you say, woof, that could have been a different outcome?
Well, it's kind of two. One of them is with me personally, and another one is with an ex-associate of mine. I remember one time a mother was in my treatment room, and she was face down on the table. And like many people at the time, it was handwritten, I was handwriting my documentation, and the table was in the corner of the room. So generally my back is almost to the patient. Now, the patient also had her 10-year-old in the room with a 10-year-old son, and he was just sort of standing on the side. I turned my back, and out of the corner of my eye, I catch her son walking over to her and slapping his mother on the butt. Just a light little touch. And then he went back to the space he was standing. And I started writing my notes, and all of a sudden I paused, and I said, that was your son who did that. And the patient looked up off the table and said, oh my God, I'm so glad you said that. I'm lying here thinking, what am I going to say? What am I going to do? Now, just imagine that, like Paul said, there's this intimidation, this fear factor, this authority issue. What if she got up off that table, left the office? She would have paid for her visit at the time, everything normal, left the office, went home and talked to somebody, let's say her husband, said, I think he slapped me on my butt. And the son never said anything. Now, all of a sudden, that progresses to a complaint. Or maybe, a board complaint or a criminal complaint, it wouldn't matter. I had my back to her. I would have no idea what this woman was talking about. And it would have been me saying, I swear to God I didn't do that. And her saying, I swear to God you did. Where do we go from there? So it can happen sometimes even innocently or casually if you're not careful or aware. I won't even use the word careful because we're going to really focus on the concept of just being aware. Another example I have is an associate of mine who was no longer an associate at the time, called me up and he said, I have a situation maybe you can help me with. We left on good terms, obviously. So he was telling me that a patient said that I am attracted to you and I'd like to date you. And so I said to him, well, we have regulations regarding that in our state. I cited the regulations to him. And that was the end of that. About 3.5, 4 months after that, he calls me up and he said, you're not going to believe this. I have another patient who's being forward with me. I said, now, granted, he was young and he was a good-looking guy and all of that, but I said to him, all right, well, same thing applies. You just tell them that it's not appropriate. I'm your doctor. We can't have this relationship until whatever. And again, citing the regulation. And then about 4 months later, he calls again and said, I don't even want to tell you, but it's happening again. I have another patient. And before he even finished saying it, I stopped him and I said, what are you doing wrong? He said, what do you mean? He said, what are you doing wrong? you're putting something out there that these people think they have that inroads to you. At the time, I had been in practice like 19 years, and I said to him, I said, either I'm like the most unattractive human being on this earth, or I just do it better, but I have never had anybody come forward to me like that. I said, so you have to recognize that there is a message you're putting out. And you have to be careful, whether it be conscious, unconscious, whether it be deliberate or not, whether it be verbal or subliminal. You have to be aware of what you're putting out there.
And some of this comes back to things we've talked about in other episodes about perspective versus perception, right? And so you've got someone coming into the office, they might have some thoughts about what chiropractic is, right? They might see some of these awful YouTube videos showing these osseous adjustments of the cervical, right? Or their friends describe it, but it's not the same chiropractor that you're going to, but they have likely some preconceived notions of what chiropractic is and isn't, right? Don't touch my neck kind of stuff, right? So
for sure.
But you have to be aware that how you practice is not going to be how your neighbor down the street practices. So it really, oftentimes, when it's not this sinister, nefarious type of action, it comes down to the informed consent. And are you providing the information about, what you do, how you do it, what they're going to experience, give them the chance to ask questions and then to consent to that care. That's oftentimes.
And a consent form isn't a form they sign when they walk in the door. It's done after the report of findings and before any treatment. They have to be informed to actually sign an informed consent.
And then part of this goes to things we talk about. So as a male massage therapist, and I'm working on clients, male or female, I am very sensitive to the nature of that dynamic. And when I'm going to be working with someone who's, I've never seen them before, but they've written on their intake that they've had massage multiple times, I don't make an assumption that they've had a massage like the massage I perform. And that doesn't mean I'm special. It just means that I'm not going to make the assumption that, what they're going to experience with my massage will be the same as that they've always experienced. So I explain it. I even have it on my consent form in generalities, and then I explain how I drape, where I touch, where I don't touch, that they can ask any questions they want. And then we proceed once they understand the do's and don'ts and things like even just, massaging their glutes, right? So, those are not small muscles on most people, and you don't want to ignore them, but I let them know that I will be doing that. And typically I'll say there'll be compressions over the drape. I'm not going to go under the drape. There's no need to go under the drape for things like that. For me, that's my opinion. Now, someone else therapists might have different opinions, and let them do what they want. But it's really about that knowledge, and it's not letting somebody know what you may do while they're lying on a table, because that authority power dynamic has now been compromised, because for them, it's going to be a lot harder to say no. They're not going to understand. So if something comes up, like for me, if something comes up on the table that I feel is going to alter typically how I would massage them, I wouldn't deal with it at that moment. I say, well, we'll have to deal with that at the next session. One, I'm building a marketing now of an expectation that they're coming back, right? But and doctors, I'm sure you do, right? You've got people that, you do a great intake, all this stuff, and then they're on the table and, oh, by the way, or as Dr. Davini said, I wasn't in it. If you heard the introductory episode, I'm not in an accident. Just, basically, what is it? What do you say? On my head for 60 feet. Does that count?
20 feet on my head.
Yeah. Does that count? Right. So that stuff does happen, but you need to have the procedures and protocols in place to pause and not continue with something just because you're trained to do it. You can do it if that patient isn't going to have the opportunity in a dynamic that isn't so powerful as them being face up or down on a table and you're standing over them.
Doctors, here's a shocker for you. Patients don't necessarily expect that you're going to touch them. Now, I know they're going to a chiropractor, and that seems silly, but there are many different ways in which chiropractors approach their care. And believe it or not, there are those that really don't touch their patients that much or at all. But your consent should definitely define the fact that you will be touching this patient, not just in the areas where they're symptomatic, but maybe in other areas through the examination process or the evaluation process. Also, you should be telling them that I am going to touch you, or there may actually be some casual contact because of the nature of my technique. One of the most common complaints for inappropriate touching comes from doctors who practice techniques that involve side posture. So they would stand there, obviously, and the knee of the patient would be between their legs, and they would do their adjustment in whatever they were taught. But just recognize the fact that their knee is between your legs. So you have to be aware. I had a situation once where a doctor was accused of inappropriate touching because they were doing some release of a muscle, the adductor muscles of the thigh. And so he wanted to go to the origin of the adductor, which is pretty high up there. And to him, it's not a big deal. It's just what he does. That's the mistake we all make. This is just what I do. I need to do this to do what I do. But to the patient that's never had this procedure performed on them, all of a sudden you're putting your hand up close to their crotch. So I had the patient actually perform the procedure. The doctor performed the procedure on me. Now, this is a doctor that's aware that they're being challenged on this procedure. This is a doctor that's aware that I'm the one scrutinizing the methodology of performing this procedure. So you would think this doctor would be like super extra careful. And in this case, after performing the procedure, I said, there was some inappropriate touching, not intended for sure. Obviously, in this situation, there's no way that it would be intended. So, but you have to recognize that your technique allowed for the possibility of inappropriate touching. So you need to take more stricter measures to avoid that. Maybe have the patient put their hand down by their crotch or a towel or something. But what I'm saying is it comes down to awareness, that you must be aware of what you're doing and where you're doing it and who you're doing it to, because they're not in the same place as you. As we said in the past podcast, if they knew what you knew, then there'd never be any questions about why they're there. But they don't know what you know. So make sure that communication is open so they do know what you know.
This makes you think about tools of practice. We teach a chiropractic assistant procedures program. We have one online. We do it in person often. And this program is teaching chiropractic assistants some clinical procedures. And one of the things that we spend a lot of time on is this whole idea of letting the patient know what you're going to do before you do it, letting them know what you're doing as you're doing it, and then letting them know what you've done when it's over. And this can be even more acute as far as following this procedure when somebody is, prone on the table, right? Because they can't see anything going on behind them. So having that comfort of explaining it beforehand, explaining it while you're doing it, explaining what was done, not only reinforces the education and, you as a professional, what you're doing, but also gives that comfort to a patient, especially the first time. And they're just not used to it. They don't know what to expect.
You can send subtle messages to patients that you're aware of this. In my office, if a patient was going through an exam and they sat on the exam table, I had a mirror facing both sides. So whether I was standing in front of the patient or behind the patient, they could always see me. Never gave this perception that something was, or the impression that something was being done behind their backs kind of thing. Women were given gowns and shorts to wear for the exam. So again, whether they cared or not to put the shorts on that's their business, but it's telling them that I am aware that there might be this discomfort of being in a gown sitting on my exam table. So, having a staff member in the room. All of these things make a difference, and you don't have to say anything. You don't have to do anything special. Yes, we're talking about making sure your scripting is correct to make sure they all understand what's going on, but these are more subtle things. These are the subliminal messages that say, I am aware of this, and I'm going to pay attention to it.
And, a couple things I'm thinking about, right, Mark, is one is tackling that patient where they're at, right? So you have their history and, if things come up in a patient's history or as you get to know them of a traumatic nature, maybe they've got a history of being abused or whatever it may be, always meet that patient where they are, right? So you know that if this person's got some touch issues already, that you don't just dive in there like it's, that 7 a.m., plumber or electrician guy who's walking in and just wants to get adjusted and get out, right? I mean, maybe they have touch issues too. You should know that, right? But and I'm not saying that every patient discloses this at the moment, but when that does happen, or you start to get your clinical senses up that there's something more, there's a hesitation, they're worried or they're nervous or whatever it may be, you want to make sure that you recognize that and address it. And your approach may be softer or different until they start to understand your procedures and you can, do what you need to do. It makes you think of another thing too. So, all right, doc, in a lot of states, chiropractors are trained in things like breast exams, right? I mean, you learned it in school, I'm assuming.
It's scope.
It's scope for a lot of them. And, maybe in super rural areas, it's something that, might be something to do. But what are your thoughts on, your typical chiropractor in a typical place? And
well, I'll give you a story. That's the good thing about getting older. You always have stories, right? So I'll give you a story. I was defending this doc who was being brought before our state board for inappropriate touching, and the doc did a breast exam. Now, in Massachusetts, it was or is within our scope to perform that exam. It's external if it's necessary, especially if it pertains to the spine-related complaints or whatever. So it's within scope. So I'm standing there, and the attorney that brought me in as the expert is also there. And I said to the doctor, I said, let's at least talk about the appropriate way or what should be done. Said, number one, I said, there has to be a clinical need. So obviously you just don't do routine breast exams on women. You must have a specific clinical need for that patient. So number two, it would be good to wear gloves, just again to put that subliminal message out that this is a clinical thing. Said number three, make sure there's appropriate draping. You don't just have the patient, drop their gown and they're fully exposed. You do what you have to do, minimum necessary, as HIPAA loves to constantly quote, right? So make sure that they're properly gowned. I said, and then use as few fingers as possible because, you don't need to have extra hands where they're not supposed to be. I said, and then the last thing is don't do it.
Exactly.
Just because you can doesn't mean you should. So think about the outcome of this. You do a breast exam on a woman, you find something. What's the first thing you're going to do? Refer them out. So the whole point here is that you're searching for something that has nothing to do with what you're doing. It puts you in a position, it puts the patient in a position, and it's not necessary. So just because you can doesn't mean you should.
And then I say to myself, why would you want the liability of that too? I mean, yes, the possible complaints and all that, but also you identify there's nothing going on with the breast tissue, and then there was something going on with the breast tissue. Now where are you at? You know what I mean?
Yeah. I'm not saying you wouldn't refer this person and say, make sure you get a breast exam, make sure you do a self-exam. But you just pointed out the perfect example of what we talked about earlier. So here's a doctor with all the clinical rationale in the world for performing the process. And here's a patient that has alternatives to that doctor performing the process, but again, is now doubting, why is a chiropractor touching me there? So here's a person who has the feeling that something is being done incorrectly or for wrong reasons. Here's a doctor that has all the clinical rationale for it, but you just said, why are they doing it? So you, as the chairman of the board of massage therapy, has someone come before them in a similar situation, and you're saying, but why did you do it? Why are you the one doing this? There's no good reason. Is this something you do routinely or do commonly? I question the need. So this is that he said, she said type of situation we're referring to, where you have to weigh all these intangibles and come up with a decision that you go, you want to know something? Let's give you the benefit of the doubt and say that you had a reason to do it and it was good. Now don't do it again.
Yeah, sometimes it's optics, right? Sometimes your patient or your client, they have trust with you, they feel comfortable, something was done, but then they go home and they talk to somebody else and optically they're like, what are you talking about? Why did they do that? I don't know. Now they're planting seeds of doubt and intention in there, and at the
all
end
for
of the
no
day,
good reason.
Right. Because if you don't find anything, you still want them to get checked out by somebody else. If you do find something, you're going to want them to get checked out by another professional. So just bypass the process real quickly.
That's it.
Stay in your lane.
This is what we're saying about being aware. And part of that awareness is be aware of the things that you should and should not be doing. And if you are going to do things that are potentially misinterpreted, make sure you have a good, sound clinical rationale, good, solid documentation. Take the safeguards like we talked about, people in the room maybe and things like that. Recognize that you have this authority over the person so you can, in a sense, intimidate them to say yes. But the bottom line is it comes out to be communication. Communication. You must do exactly what Paul had mentioned earlier. Tell them what you're going to do. Tell them why you're doing it. Tell them why you did it. Do you have any questions? And give them a fair opportunity to say yes and no.
And it really goes back to that informed consent. And yeah, you might have to change your process a little bit, because if you're giving them this consent form with all the other intake paperwork, it's not, as we said, a valid informed consent. The doctor should have it in their office so that once the ROF happens, before they get on that table to get adjusted, that is the time. And if you're a 2-day ROF, then before they come in, or as the second day approaches and they're walking in for the adjustment part of it, whatever it may be, before that first treatment, lay on that informed consent, make sure they have no questions, make sure all the things we've touched on happen, because
every pun intended.
Yeah, exactly. Otherwise, it becomes a touchy subject, doesn't it?
Exactly. Exactly. How's that for a closing? So,
all right. Well, thanks again for joining us for another episode of All Things Chiropractic. I'm Paul Andrews.
And I'm Dr. Mark Davini.
Have a great day.
Thank you.
Thanks for listening to All Things Chiropractic. We'd love to hear from you. Visit allthingschiropractic.com with comments, episode ideas, or questions. Or connect with us on Facebook and Instagram at All Things Chiropractic Podcast. Be sure to join Dr. Mark Davini and Paul Andrews next time for another episode of All Things Chiropractic.